All right, thanks everybody. I want to first thank the board for being here. My name is Mahmoud Sabawi. I have my partners Karen Wright, Cindy Dunlap, and Jeffrey Edwards here today, and we are Innovation Health Strategies, and we're going to talk to you about how we can improve the stroke situation down in Kentucky. So this is how our presentation's organized. We're going to start with a brief case review. We're going to go over the root cause analysis, and from the causes we've identified, we're going to make some recommendations and how to implement these recommendations. Then we're going to also provide a financial assessment, and in the end, we're going to put everything together and provide a conclusion. So let's talk about Lynette. This is our example here. She's a 53-year-old female who reports herself as healthy. She walked to and from work. She wasn't on any medications, but she also did not have any insurance or a PCP. She finally got insurance when the Affordable Care Act kicked in, but she still didn't establish a PCP. On June 30th, 2014, all of that changed. Lynette suffered an ischemic stroke, and then her experience with the healthcare system wasn't very good. It suffered from lack of health education delivered to her and her family. There was a lack of communication between healthcare professionals, and that included lack of appropriate documentation and poor transitions of care from facility to facility and also to discharge. And then the South Tree Health Network as well as Ginkgo Grove had a lack of resources, and if you put all that together, it leads to decreased quality of care. And I really want to stress that Lynette is not an isolated incident. And Lynette is a typical person in Kentucky, and a lot of stroke victims actually suffer the same episode that Lynette has suffered. So I want to talk about a few stroke statistics. Now, the deeper the purple, the higher the incidence of stroke. So if you look, Kentucky's around this region right here. It's pretty dark purple. They suffer from a high incidence of stroke. And in the U.S. in general, stroke is the third leading cause of death and the leading cause of disability. So even stroke survivors suffer disability after the stroke. The good news is at least half of them can gain functional independence after successful rehab, but that requires early and high quality interprofessional care to make sure that happens. And also talking about stroke, over a majority of them are ischemic strokes, and that's the kind that Lynette suffered, and a large percentage of them, the pluralities in the geriatric population. And that's why Innovation Health Strategies is going to talk about not just treatment of stroke, but also how to prevent stroke. That's an important part of our focus today. So I want to talk about the 3D model of health decline. It starts with the patient having a disease. The disease leads to patient having disability, and those disabilities lead to the patient getting depressed. Depression itself is a risk factor for other diseases, starts a cycle all over again, and just leads to the patient's health deteriorating over time. And I want to share a quote from the Kentucky Stroke Encounter Quality Improvement Project. And they say that their goal is to implement evidence-based integrated cardiovascular health delivery systems and to support and advance the quality of care available to stroke patients. The question Innovation Health Strategies is going to answer today is how can we help? And to do that, I'm going to have Karen talk about the root cause analysis.
All right. Thank you, Mahmoud. So our charge at Health Innovation Strategies was bigger than just this one case, but this case epitomized what was wrong with healthcare in this region. And so what we did, our next step was to do a root cause analysis, and we used this case to do our analysis. If you want a little more detail, you can refer to our fishbone that's on page 3 of our appendix. So Lynette's illness was a perfect example of systems, processes, and people lining up together, kind of that proverbial Swiss cheese effect that resulted in bad outcomes for this patient. Communication failures were perhaps the biggest problems that occurred, but health system failures, community deficits, and then also the patient characteristics themselves really played into the bad outcomes for this patient. So I mentioned communication failures. Lack of communication and miscommunication is really showing up in the literature as one of the most significant factors that lead to harm for the patients that we care for. And then this resulted in missed opportunities to really identify, examine, and then address the specific problems that were present. I don't know what button I pushed. Thank you. Healthcare system failures were also a component in the failures here. Isolated practitioners, practitioner preference, and siloed care was really the norm in this situation. And this resulted in a lack of coordinated care and examples of miscare. They really did not have evidence-based care bundles that were patient-centered to pick up on some of these misses. An example would be evidence-based team training would be a significant first step that would mitigate some of these barriers. Community deficits were also an issue here. There did not appear to be a community health assessment plan. There was lack of access to primary care, of course, socioeconomic characteristics, and this resulted in a lack of an infrastructure. So the patients and families in this situation really didn't have an infrastructure that promoted health and wellness in the community. And then patient characteristics. And what you'll notice in our root cause analysis is that a number of these things that we identified showed up in each of the different root causes. So poor healthcare literacy, again, the socioeconomic barriers, and as we mentioned before, the patient perception of their own health and wellness. And so the patient didn't have the tools that they needed to advocate for themselves and for their family members. So Innovation Health Solutions decided to implement the Wagner's chronic care model to help us begin to redesign healthcare in this region. And the reason we did is that this model provides an excellent structure. It really encompasses the different components that were identified in the root cause analysis that were missing, and helped us start to take a real focused approach at redesigning healthcare. So we are proud to propose really a three-pronged approach to meet that triple aim: to improve the health outcomes for our patients, to decrease costs, and then also to improve the patient experience in the system. Our first recommendation would be the development of a regional health council. Second, institute a member accountability program. And then our third proposal is to enter into a shared savings plan with Bluegrass Blue Shield Healthcare. And my colleague Cindy in just a moment is going to go more in depth in our recommendations. So I just wanted to revisit this model again because you can see it's starting to take shape. South Tree Health Network, the healthcare system, as well as the community are coming together to start to solve some of the problems to meet that triple aim and improve the health of the population that we serve. Now I will pass it over to my colleague.
The Kentucky Health Council will design and implement a regional approach to address the communication failures and the healthcare system failures as seen in Lynette's case. The overall goal is to improve patient satisfaction, to improve health outcomes, and decrease costs per the triple aim. The next three slides identify the key institutions that the network should partner with to form the council. Under each institution, tactics are recommended that the network should partner with the council for collaboration and implementation. The tactics of the council would assist the network to improve the social and health determinants of the community's population. Lastly, the council should engage all healthcare providers in these initiatives with funding support coming from grants, community agencies, governmental funding opportunities, along with foundation. The outcomes and process metrics listed are recommended by our consulting group to gauge the success of the council. Additional metrics can be easily determined and added by the council as we move forward collectively. While step one focuses on the community's health and while step one is focused on the community's health and resources, you, the South Tree Health Network, has the grand opportunity to address the root causes in Lynette's case. By strengthening your internal infrastructure, STHN should execute on evidence-based practices and develop a care transition plan for each of your patients with your member institutions to drive out waste and hit your operational metrics. Each institution of your network has significant contributions to make to the collective outcomes of your patients. That includes your providers, your hospitals, long-term acute rehab, your home care hospitals, and all of your contracted vendors, including outpatient therapies. This slide represents the deliverables that should be driven by your physicians and advanced practice professionals to execute and implement evidence-based protocols and ensure great access to care. These metrics supporting the Step 2 mirror the Kentucky Health Now program along with the Affordable Care Act medical home metrics. The last recommendation of our consulting group is threefold in approach. First, to transition from fee-for-service to capitation over time, to develop a care coordination program, and lastly, return financial savings to the STHN providers of care. Innovation Health Services recommends that STHN enters into an agreement for a shared savings program with Blue Cross and Blue Shield to develop a care coordination program, a form of a primary care medical home. The goals and team ratios are the key financial assumptions which drive the cost-benefit analysis as seen in your executive summary on pages 4 through 8. The focus of our consulting team has been on the shared savings program. However, you as the network should truly evaluate the care of your acute ischemic stroke patients for best in practices amongst your facilities and entered into an agreement for a bundled payment plan with Blue Cross and Blue Shield. Guided by the physicians and the advanced practice professionals, the care coordination team has a list of critical activities that must be accomplished. A key failure in Lynette's case was that she was an enrollee of a health exchange program. However, she was not solicited for any health care appointments or health screenings. Applying her case into our recommendations, this care coordination team would have actively pursued Lynette until she received the appropriate preventative and medical care. This picture demonstrates that 80% of any population typically are well and can be managed through televox and healthcare appointments, with the remaining 20% of rising or high-risk patients supported either by a medical assistant, health coordinator, and or a health coach. In the case of STHN, we are recommending that the 80% of the population be managed by a medical assistant health coordinator, with the 20% being managed by an RN health coach. With Kentucky's challenge of disengaged patients, this intense focus will allow, in our opinion, for early success of the program. As we gain momentum and success, STHN could realign the ratios based upon the results of the program. The goal of Step 3 is for STHN to gain the experience in care management for enrollees, getting all of us ready for capitation by year 6. As you see with all of our metrics identified, these are the ones that we consider for success. I will now transition and give the laser to Jeffrey.
Thank you. So, taking a closer look at the financial assessment of our recommendations based on a thorough review of the current state of affairs for the state of Kentucky, as well as a systematic evaluation of the overall healthcare climate in the United States, it is our recommendation to you that South Tree Health Network should enter into a shared savings plan with Blue Cross Blue Shield. Now, under this new arrangement, Blue Cross Blue Shield would be able to partially finance the care coordination program at a rate of only $3 per member per month. This new arrangement would also allow for other benefits like forged reductions in cost of care, improved health and wellness for the population at large, and it would also allow the network to develop the infrastructure for population management on such a large scale. And then again, after the hard work of years 1 through 5 as listed up there will be solid foundational support for a full at-risk relationship between the network and Blue Cross Blue Shield via a capitation agreement starting in year 6. So, as Cindy said earlier, one of the main focuses for us was to reduce the inpatient admissions, ER visits, and inpatient readmissions. And in column 1, you will see the statistics for the state of Kentucky as of 2009. Now, based on our research, as well as a statistical analysis from the implementation of a similar program in another healthcare system, we would propose the following reductions seen there in column 2. And while you might look at those proposed reductions and think that they are ambitious, we think that they are feasibly attainable. Column 3, therefore, shows the cost per visit or cost per stay. And what that does is allow you to put a real dollar amount on the savings that will be going back into the network and Blue Cross Blue Shield. Here is our overall cost-benefit analysis, and this is in your appendix as well. And what you will see is that the total at the bottom is your 5-year total of net savings of over $800,000. And while this is by no means insignificant, it also cannot truly capture the full potential of this plan. As we said before, this first 5 years is setting the stage for capitation in year 6. We would also expect to see a continued increase in the rate of savings as the care coordination program really takes off after the first few years. As with many projects, we are forced to make assumptions in developing our cost-benefit analysis, and we are forced to make some rather significant, but I still think reasonable assumptions, namely that the cost of materials, salaries, but also reduction costs via QI projects would either remain constant or at least remain at a constant rate of growth or decline. And we have some more numbers in their appendix if you want some more definites. We also did not factor in things like a lack or loss of reimbursement due to unnecessary care, nor did we factor in things like bundled payments. We would also point out that there are potential for savings that we did not include in our analysis, things like the development of a generic formulary from our pharmacy department, keeping all or at least a lot of referrals in network, and the use of data analytics for predictive modeling and trending. Like with any project of this broad a scale, there are going to be challenges that come up, but we feel that with your leadership making such a strong commitment to the plan and its execution, as well as a steady resolve to do what's in the best interest of the population of Kentucky, that these challenges will not only be minimized, but they will also be overcome. And so here we have our recommendations, our final recommendations for you. And what you'll see is that we have the Kentucky Regional Health Council operating synergistically with the hospitals, with the government, with the communities, all under the financial umbrella of this new agreement between South Street Health Network and Blue Cross Blue Shield, all working toward the same goal, which is better patient care for the people of Kentucky, people like Lynette. Because if you think about it, you all know Lynette. You've got a mother, a sister, a wife, a partner, a friend, somebody that's been affected by stroke. And you know that when you have to live with the devastating effects of stroke, that's in fact no way to live. And I think we can all agree that something has to be done to make that better. The people of Kentucky, especially this part of Kentucky, need leadership. They need somebody to fight this fight for them. And we think that you can be those leaders at the forefront of this fight, and we think that you can win that fight, and we want to be the ones to help you do that. Thank you very much for your time. We'd be happy to answer any questions that you may have.
Okay, very clear, and thank you very much. Go ahead. What kind of infrastructure will be needed for the, blanking on the name of it now, the council, the Regional Health Council?
Well, like it was evident pretty early on in the case scenario, there needs to be more rural health buildings, whether it's clinics, community hospitals, a place that can operate as health screenings. There needs to be more of those, and they need to be more readily available to prevent the travel from these rural areas into town. So that's one of the things that's going to have to be addressed, and there will also therefore need to be equipment, computers, electronic medical records, things to go in those new buildings. That's one part of it.
In the Regional Health Council, our idea around that is there are a number of models across the country that partner the different, often competing healthcare institutions in the community with community members to come together and really solve. And so we would base that Regional Health Council on some of those models that we've seen in other places in the country to really bring all the players together to solve some of the problems in that region. And so, you know, we would partner the churches, the providers, as well as the medical institutions and other community members into that Regional Health Council. As far as facilities and whatnot for that, it's probably what is already in place at the beginning to start to come together and see how best to do that. As they go forward, then they would have the opportunity through grants and other things to start to develop the infrastructure needed for their regional health council.
So how will you incentivize their participation, and what sort of authority are they going to have to act on some of these improvements?
So I think what we have to be able to do is build upon relationships that we have in the community and call upon them to be a part of the fight to improve our communities collectively. That not any one institution can stand alone, that we need to collectively come together and really deal with the social and health determinants that move us forward. So it's my personal opinion that people in those types of positions are interested in their community. They want for their community to do better. And so through those linkage of partnerships and understanding of what their needs are, what the council's needs are, and what the network's needs are, we can collectively come together to build a community that's much more successful for the individuals' lives that live in that area.
And for example, workforce development. So it would be in their best interest to come together as a group, look at workforce development issues, what are the resources in the community, where can we partner together to meet those workforce development needs. It's really that shared table.
And since we promoted a shared cost savings, they're going to be partaking in the risk, but also the benefits. So the cost savings they're going to get is going to incentivize them. They want those cost savings, and they're going to put the effort into that.
So let's talk a little bit about the financial model, because what I liked was the 5-year progression. You made some growth assumptions, and we're looking at things on a per member basis, and that helps us look at that. We're a network. We don't have a balance sheet, so risk assumption has its ebbs and flows of cash, et cetera. Yeah. So I'm kind of wondering how, over the 5-year period, we're gonna look at the balance sheet. Are we gonna build our own balance sheet? Are there other mechanisms to do that? And the other is, it seems to me that as we do a better and better job of taking care of these high risk and high resource use patients, are we at risk of adverse selection in terms of getting more of those than maybe the economic models would otherwise suggest? And should we be thinking about that?
Coming up with a balanced financial sheet may be very difficult at first. However, I think as a network, you do have the opportunity to come together and have some hard conversations about how to move this initiative forward. It may be that one of your members, probably the hospitals, typically may be driving this, and so they may put 50 to 75% of the necessary resources in place to start this shared savings program, and then others may want to contribute accordingly to make that a viable shared savings program with Bluegrass. So there's probably some different ways to look at creating that virtual or creative financial bottom line, mm-hmm. But to not take any step forward would keep this region from moving forward towards what ultimately is wanted by all, a better population with reduced costs.
I agree with your point. I'm just trying to think about how might I do this, or how might we do this in a responsible way. And
the
I don't know. A lot of the other, be it medical groups or home health agencies, they're not. The hospital's sort of the big guy, and they're a little afeared of whether they're going to get their fair share. So we, as a network, are ideally suited to be get at this allocation, et cetera. But how to do it over time, and 100,000 members, that's a lot of cap.
Yeah, and as we move to the population health, I think we're going to see that shift from our acute care settings to those, and I think that's part of what we do with those community partners. And I also think, as far as the adverse selection, we are going to be spending time. You saw that we had a medical assistant health coach. And so I think there's real benefit in working with the rest of the community as far as health and wellness, and some realization there also of being able to mitigate maybe a little bit of that adverse selection for that risk population.
And another thing is we live in an evidence-based world, and evidence-based medicine can change month to month. And so and the way to continue forward is we can check the budget every 6 months and see, are we doing everything correctly? So in terms of moving on, we can have biannual checks or even more recent than that and get together and see how we can change our plan if necessary.
Thank you.
I get confused easily with numbers. I'm not a finance person. So I'm trying to take this particular chart, and then in Appendix F, you have the care coordinated plan savings. And what I don't quite know is the bottom line on the appendix where it takes the reduction in inpatient admissions, ER visits, and that, and then the expense in year one is $616,000. And here on your graph, is that what the care savings is? And it's $644,000. I'm not sure. I don't know what the numbers are.
Actually, what you're seeing on this slide 34 is an overall summary of the financial components built in the summary. So what you are looking at is actually based upon the projected incidence of ER visits or inpatient readmissions or inpatient admissions. We're taking that and calculating it to get to a cost of what it's occurring today in Kentucky. Then we're looking at the expense of the care coordination program, which is on a different page within the executive summary. So then taking also the actual salary expenses, and you're combining all of that to create this summary sheet of what you're seeing with the bottom line financial support of $850,000.
No, what I was saying is the care savings there, is that different than the care coordination plan savings?
That's what's up on the screen.
You were talking about Appendix E or F? I'm sorry.
It was F.
F.
Right there. It's 616 is what you're referencing.
Yeah, and it's 640. I just don't know. Are they the same thing, or it's just a minor point?
Right, and
It's something I'm sure you will clarify.
we will clarify. Right, right. And
I don't
the
have
care
any other
coordination
questions, so I had to come up
program
with
is a
something.
separate- right, the care coordination program is a separate piece in that. So.
And we had a lot of Excel sheets at play, so
How are we doing on time? Okay, just looking at this, I looked at columns and said, okay. And so care coordination support is revenue to the network from the Blue Cross plan for care coordination. So what it looks like is that we're converting a whole lot of care dollars into administrative dollars for care coordination. I mean, it would seem like over time we'd be getting, incremental benefits in doing that.
Well, and I think what you're seeing, again, the first 5 years are not expected to be the trend for the 5 years after that. And there will be more funds needed at first for support.
So startup phenomenon.
Right.
yeah, I think right now we have lack of staffing in a lot of different areas, so that's part of the care coordination. That's why it needs a lot of money at first. But once we reach capitation, that's going to change.
The other comment briefly is that this is just reducing ER visits, inpatient admissions, and readmissions. It's not looking at trying to really move forward on reduction in the scope of formulary inpatient, or keeping referrals within the network, because some of these programs that have been mimicked in other parts of the country are decreasing per member per month as much as 7% in the first year.
Yeah, the observation was, the care savings are taking waste out of the system. It's unnecessary care that can be prevented in a way without impacting quality negatively. But the cost to do that is almost equal to the waste you're taking out.
Right.
So the initial
We will start
point
to
is a powerful
capture.
point.
Correct, absolutely.
This is just one just point. The care coordination expenses, real dollars. The care coordination support, real dollars. Care savings, not real dollars. Those dollars have to come from something, so something's got to be eliminated in the system. So if you reduce ER visits, but you've got to reduce the expense that goes along with the visit in order for that to be real money.
Yep, yep, yes,
So-
exactly, exactly, yeah, yeah.
So I'll start. Great job, and I'm just picking on you. And,
Yeah.
and the one thing is that this happens all the time where consultants come in and they have columns and they don't add up, and it just drives everybody nuts, and they'll pick on you for that. So I just was being minuscule. I really like the idea that you behaved as consultants. You had a moniker or an icon, and you treated us as a board, and you treated yourself as consultants. That was well done. Good acting. I like that you started with a patient story. Good stroke facts. You captured us with that emotional draw. And the emotional close was good too. You brought it back to the patient. So emotion to facts to emotion was good. Surprisingly, it's not surprisingly, but a good analysis. But what came along with that was the conclusions. I like your wishbone. You took a complex thing, made it into a column, but there wasn't just listing out everything. You had a conclusion at the end that was quite helpful. A really good presentation. If I were going to pick on some things, you had a little bit of jargon. Not everybody's going to remember Ed Wagner's model of care because it's been around for a long time. The Swiss cheese analogy, was it because there's holes in the systems or because the place stunk? I mean, there's just...
Yes. I was assuming you were healthcare people. We speak about the Swiss cheese effect all the time.
and it's just the idea that sometimes on a board, you don't know where they're coming from in the background, and sometimes you may say things and they'll be thinking about what that goes. But that was rather minor. You were good on your presentation. A few of the slides were a little busy, that distracted from it, but in general, the slides were really good.
Okay. Number of things. Both, I think, individually and as a group, you're very strong. So congratulations on that. I liked towards the end, you described what Lynette's experience would be if your recommendations had been in place. And I must say I've been looking for that consistently and haven't always seen it, so that's a good thing. You also didn't read the slides. You basically, the slides are there, you picked a few things to concentrate, and then the key kind of conclusion, particularly when you're going through the fishbone. There was really both the whole analysis as well as how you presented that. I liked a lot. You talked about Lynette's experience, not an isolated experience. You personalize it, and I think the comments about friends or relatives or whatever, and yeah, I have a friend like that, and that was a big deal. You brought up interprofessional very early on. I could have used a little more of that over time. I mean, you talked about the care team, but the important nature of individuals getting training in compartments and then coming together, just as your experience here is. I like the 3D model. That made a lot of sense. It was a good way of picturing it. As well as Ed Wagner's chronic care model, which I am familiar with. Let's see. The shared savings things, I mean, you did a good enough job that I had to come up with something to make you a little uncomfortable. So, at the adverse point, I think there's a good answer about focusing on health promotion. The other is having the data to go back to the payer to go prove that you're getting adverse selection, and that the other folks who might be getting CAP are actually getting a sweet deal because you've got the adverse selection. That's another answer to that one. But I think you took a real tough question and handled it quite well. So on balance, very, very nicely done.
Yeah, it was a nice transition to capitation. It was one that made sense.
Agree with everything my colleagues brought up. I thought you did a really thorough job of analysis. I thought you understood the problem very well and demonstrated your approach to getting to that understanding. You had a great detail despite any math problems in your financial model. I mean, your financial model was really, your approach was good. You provided a lot of detail, and it is easy to lose track. And he's right, nothing derails a presentation more than columns that don't add up, because the physician in the room will go after you when your math doesn't work. So despite that, I thought the financial analysis was really good, and you brought a lot of detail to it. The appendix generally was a really nicely put together and very good, and consistent with sort of your theme of we're a consulting group, and here's our executive summary and our analysis. The metrics, I think you could have expanded on the metrics a little bit, how you were going to collect them and how you'd use them as a system over time as we got through this. I think even how you define what's better care and what's better health. I don't know, is number of screenings better health or is it better care? I think that if I was, in addition to what they've added, if there was something I would say could have been a little stronger, maybe the discussion of the metrics and some of the population-based metrics that we might want to see. But overall, great job. Fantastic. Thank you.
Thank you very much.
Thank you very much. Dropping cards.